Okay, you'll see the number of participants start to go up. Welcome those who are arriving to the PIHCI Learning Series. We're just going to wait a minute or two and for a few more people to sign on, and then we'll get the session started. Okay, we'll wait one more minute and then I'm going to start where, yeah, we got a good number of people on. Good morning or good afternoon, everyone, depending on where you're sitting. I would like to welcome you to the Primary and Integrated Healthcare Networks Fall and Winter Learning Series. My name is Jillian Bartlett. I am a professor in family medicine and I'm the executive director of the Network Coordinating Office for PIHCI, which is our delightful acronym for our network of networks. I'm very, very pleased to launch our first network of the fall, our first learning series of the fall that is co-sponsored by the Northwest Territories PIHCI Network. And this session is supporting an innovations platform for Indigenous primary healthcare in Alberta. And we're going to hear from different members of the Indigenous Primary Healthcare and Policy Research Network. So we're very, very pleased. We've been planning this session for a while, and I'm glad to see it come to fruition. Before we get started and I turn it over to the speakers, I'm just going to go over a few things that are specific to the webinar platform, Zoom platform. The first is that as webinar attendees, you will not be able to actually verbally speak to us or the panel members. You have two ways to communicate with us. In the chat, which is just the little call out button on the bottom, if you click on that, any comments you put there, as long as you've clicked on all panelists and attendees, everyone will see that comment. So if you have a comment, I encourage you to put it there. If you have a question for the panelists, go to the Q&A button. If you click on it, you'll see that there's the ability to enter your question there. You can do this with your name or you can do it anonymously. We will be answering those live and you can direct those at a specific speaker or not. I will be reading those out during the Q&A session. S'il y a quelqu'un sur la ligne qui est plus confortable en français, certainement, vous pouvez demander la question en français. Ça va être, la réponse va être en anglais, mais je peux aussi faire la traduction. Alors, vas-y, être à l'aise pour faire la question en français. This will be presented in English, but I will facilitate any questions that you would like to, if you're more comfortable to ask them in French. I will ask our panelists a question in English, but I will also summarize the response in French. Keeps up my French skills. So that is the format for the panels. I would like to, before we get started, read an acknowledgement. This is a statement of acknowledgement of traditional land for virtual meetings because many of us sit on different territories. And this was developed by the Canadian College of Family Physicians Indigenous Health Working Group. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you're calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. So with that, I am going to, we have three panel members. We have Dr. Stephanie Montesanti, we have Dr. Lyndon Crowshoe, and we have Elder Leonard Bastian. They will be introducing themselves. As they speak, I'm going to turn off mute myself and turn off my video. while they're talking, but please feel free to post in the chat in the Q&A, and we will deal with those questions and comments after this session. So Stephanie, I'll turn it over to you, and I look forward to hearing what you have to say.
Great. Thank you so much, Jillian, for the warm welcome and introduction, as well as the invitation to share about our new and exciting Indigenous primary healthcare and policy research network in Alberta. So I'd like to begin by acknowledging that I live and work on Treaty 6 territory. And Dr. Croshoe and Elder Lennon Pristine are joining us from Treaty 7 and home to Métis Region 3 and 4. And I'm very fortunate to have the opportunity to work with many First Nations and Métis communities across our province, and grateful for their engagement in our network, which we'll talk about today. So with that, I'll start us off. So today we're going to talk about supporting an innovation platform for Indigenous primary healthcare. So I'll begin by way of a brief background. Indigenous people's experience within the healthcare system in terms of accessing health services has been more complex than it is for other Canadians. For Indigenous people worldwide, accessing primary healthcare responsive to sociocultural realities is challenging, with institutional inequities in healthcare and jurisdictional barriers, which often influence or change their experience and navigation through the health system. Here in Alberta, we know that policy reform has been hindered by complex networks and competing interests, which include between federal provincial funders, reserve, on reserve, or off reserve context, the relationship between medical and allied healthcare professionals, and priorities or conflicting priorities and values between healthcare providers and patients, as well as the complexity in navigating 3 treaty territories. We've also, through work that members of our network have done, we've learned that Indigenous patients' interaction with the health system in Alberta and their engagement with the health system has been influenced by personal and collective historical experiences with healthcare providers, as well as their experience with culturally unsafe healthcare. The primary healthcare policy landscape and innovation challenge in Alberta is really what drove our interest in establishing this network. In the province, we've experienced a lack of integration of Indigenous primary healthcare services, which has really been incomplete, experienced by inequities in resources, and there have been pockets of promising innovation that we've seen across the province. And our interest is really in strengthening those innovations, the Indigenous-led models of care, and strengths within the communities. The challenge ahead involves how best to scale pockets of innovations towards integrated initiatives with measurable impacts across Indigenous health systems. And driving that is strong evidence and knowledge, not just evidence from science or research, but the knowledge that's held within communities, within Indigenous knowledge systems, and the guidance of elders and community members. So this is the principal investigators that are leading our Indigenous primary healthcare and policy research network. It is led by Dr. Lindsay Croshoe out of the U of C. And the principal investigators include a range of researchers across the province from 4 main institutions. So actually Queen's University is also included with Dr. Mike Green, but across the University of Calgary, University of Alberta, and Mount Royal here in Alberta. So these are our principal investigators. We meet monthly to talk about our priorities, addressing our core objectives for our network, innovating together in terms of sharing ideas, and planning and organizing a number of exciting opportunities, including webinars and seminars that really foster knowledge exchange and engagement in Indigenous primary healthcare research. So how did the network begin? So in the spring of 2019, we convened 65 stakeholders from across Alberta for 2 full-day roundtable meetings to provide direction for a proposed Canadian Canadian Institutes for Health Research Network Environments for Indigenous Health Research, otherwise known as NEAR, um, proposal that focused on primary healthcare and policy research. So the purpose of this Indigenous primary healthcare and policy research network is to generate capacity and collaboration in primary healthcare innovation and collaboration in primary healthcare research, addressing inequities in Indigenous primary healthcare, and key directions for building research capacity in Indigenous primary healthcare and policy research. The roundtable discussions were convened around 3 main questions, which included 1, considering existing gaps and needs, what primary healthcare resources are critical to advocate for. And again, given the diversity of stakeholders we brought together, we had service providers working either on reserve or in urban settings and across both the north and south zones in our province. So really thinking about how we can address those gaps and needs across the region, across the province. Secondly, we gathered around the question of upstream approaches to health. So how can primary healthcare be better equipped to address the upstream social causes of poor health? And lastly, knowing that multi-generational impacts play a role in Indigenous health outcomes. If healing involves addressing those impacts from multi-generational life experiences, then what is needed for primary healthcare to play a key role in this healing? And I just wanted to highlight some key directions that were brought forward from those 2 roundtable discussions that we had. And these were directions for Indigenous primary healthcare research. And 3 key themes emerged from that discussion. 1, pertaining to research. So by conducting community-based research, the gaps and needs around primary healthcare delivery can be better understood. Equity was another key theme that emerged in our conversations around directions for Indigenous primary healthcare. And the conversation around equity centered on this responsibility to not perpetuate racism, bias, and stereotyping, and addressing jurisdictional barriers. So really building on Indigenous-led models of care and strengths within the community. And lastly, a 3rd core theme that emerged around directions for primary healthcare centered around engagement. So through partnerships in healing, primary healthcare can help Indigenous peoples in healing and should also take a broader approach in its role to aid in healing, recognizing the unique role of the individual, family, and community factors that play a role in healing. So with that, I'm going to hand it over to Dr. Lindsay Crochue, who's going to introduce our network.
Thanks, Stephanie, and thanks for the invitation to speak today for this network of networks. The few words to say. I think it's a privilege to be able to engage in this work with community and with colleagues and with systems. It feels to be an important space to facilitate, because I think there's some important things that we have to do within Indigenous primary healthcare and policy. Thinking about what and why this was important as a family doctor. That's my background. I worked in mostly Indigenous communities throughout my career, except for in the early days when I did work with the AMA Rural Locum program that allowed me to travel to many rural communities to get a flavor and a sense of various types of practices, various types of contexts, and what are those outcomes. And so that allowed me to get a bit of a sense of what I would like to do and see within Indigenous health. And in my career, I had roles in supporting the development of primary health care within First Nations communities, as well as within then Calgary Health Region, now the AHS. So my background has been sort of pushing as an academic, pushing the and developing and engaging in the concepts of primary health care, which was very empowering for me as a family doctor. And what does it mean for in the Indigenous context? So my background is harnessing an academic role to help to support and understand directions for improving primary healthcare systems for Indigenous people. So my work has been in the facilitation and development of an urban Indigenous healthcare center called the Elbow River Healing Lodge, which has a certain certain model of care that's grounded in a host of all of these concepts that we put on the table today, and supporting some First Nations communities and moving forward in primary healthcare models that has been a pleasure to be able to like think through this stuff. In my sort of early-ish days, I always felt that that Indigenous primary health care was quite unique in the sense that we had to integrate a whole host of knowledge sets in order to do our job well. It's mainstream concepts, so the biological, the biomedical, and the emerging sort of concepts within family medicine that are really important, but that wasn't enough. And so we had to I see the need to understand how structural violence, and all those components that drive poor health outcomes at those upstream levels that get reinforced within systems, and how Indigenous people experience the world. What does that mean for primary care? And like those questions those guiding questions that Stephanie mentioned, the ideas of to truly understand the implications of social trauma from residential schools, or but more broadly colonization. What is it that we need to understand and do within primary healthcare to really play a difference in this healing when our systems seem to be not quite in line with what is required to support Indigenous people? So that's where we sit. And the other idea was that as within Indigenous primary healthcare, we then have if we sit ourselves within this interdisciplinary, and I argue a transdisciplinary space where we work across the board with population health concepts, social sciences, policy, clinical sciences, Indigenous ways of knowing as a whole unique and important sort of construct, knowledge base. If we build these together, bring them together, and all of a sudden we're creating and doing something different. It's very transdisciplinary. And I see, and I had this vision that we saw ourselves as not just knowledge users within Indigenous primary healthcare, but knowledge generators, because we're in this privileged space that allows us to think outside of the typical primary healthcare box. And we actually had need to like develop this in order to like find this knowledge that often exists in local settings across Canada, across the world, that Indigenous people within Indigenous primary health care settings are doing some amazing things that if we could just like harness that, we could like learn a lot. But also there's some specific things from the gamut of policy all the way to practice that need some support in addressing the gap. And by harnessing a research lens, a research set of methodologies, and if we can put that on the table with the typical health services conversations that I've been at the table for decades, maybe we can shift the tides. So that was the intent of this network, was to promote a renewed and transformed primary healthcare system for and with Indigenous peoples to achieve a better state. And so equity is a construct that we hold here. And we do so via a research lens. I know that there's advocacy and a whole host of organizational components and all that stuff that I fully appreciate stakeholders when they come to the table to address this stuff, right? Within a provincial and federal health system concept that integrates sort of reserve-based sort of leadership and advocacy through the chiefs, and then advocacy through a growing urban sort of context and a very strong Métis sort of component. That is a table that has trouble sometimes by not communicating as we lobby. Anyway, so my intention for this was to create enough capacity for us to like understand and see knowledge and see in its in a clear way to help support a stakeholder conversation, a dialogue that happens all the time. If we can shift that tide and move things forward because of great knowledge exchange, then I think it's gonna move us into our overall intention. Anyway, that's the big picture stuff. Can I have the next slide, or do I have control of this? No, I don't. Perfect. Thank you. So as Stephanie was mentioning, we based our conversations to create the big picture of this from those three questions. And by the way, those questions were grounded within the Truth and Reconciliation. Within the Cummings School of Medicine, we actually looked at those 7 calls to action, and we did a Indigenous focused interpretive process to identify what are the truths, what are the principles, what are the directions. And within that, we saw a host of clear questions that seemed to resonate across the board, not just for a medical school for teaching and learning, but also at a health services level. So I use those that earlier work to then guide the formation of this network. So it's truly connected to the concepts and the intent of the Truth and Reconciliation. So we actually feel that's a huge strength, and are super proud to like share that we are directly connected to those concepts and wanted to honor that. Our principles that came about from these conversations, which I thought were very formative, very influential, and we worked really hard to ensure that we respected the voices during and then after with the analysis. Strengths-based, right, is one concept. It's a concept that can easily be dislocated, but so we need to like make sure that rather than modeling a deficit and influencing and seeing only a lens of deficit, that we actually look also and focus on a strengths-based approach to building resilience within working with Indigenous peoples within this network. That an Indigenous knowledge, as I mentioned, is part of the importance. It's critical to the importance and critical to this transdisciplinary space that I see we sit ourselves in. That Indigenous knowledge and the ethics connected to that is central, because it frames how we do it. It frames how we engage with each other, and it frames how we connect with knowledge, right? And how we center and privilege knowledge. The next principle is addressing those disparities, right? So it's really connected to those 3 questions that we showed you earlier. Understanding there's structural issues at play here, and what is it that happens as it creates and facilitates healthcare disparities that then has limited capacity to do its job. So we feel that there's a role to understand the interplay of structural violence, structural issues, disparities, and what it means to a healthcare service that can perpetuate that. So we have to undo that. So that sort of has all that racism sort of constructs that we need to work through here. The next principle is that the working with community, which is a very broad sort of series of concepts that, in terms of who is community, a community of Indigenous peoples, of Métis people, on-reserve people, urban-based people, clinicians who work within Indigenous populations for their whole life and have served and have learned and figured it out, even if they're non-Indigenous, Indigenous professionals that work clinically as well as at a research level, non-Indigenous organizations that are committed committed to this. There's a whole broad range of communities that we feel offers opportunity for us to connect to in this transformational process. And we also feel that to truly understand and to push the boundaries, measurement is key to this. So it becomes a part of what we see ourselves sort of engaging in the metrics, the validation, the identifying of appropriate sort of tools, concepts and tools, indicators, and then ensuring that they are robust and validated. Can I have the next slide and tell me if I'm going like just talking too much? So, okay. Just put your thumb down, Stephanie. It's like, hurry up. Right. Our aims. So we thought long and hard about, well, what is a network, right? and so these are the questions that I would bring to the table to the team here. Like, oh, so what do networks really do? Like, I know we say it all the time. So we needed to do a bit of searching and thinking. So we feel that based on what we're sort of having conversations around, that our aims around this network is around partnership and trust, right? It's like this relational component, right? So strengthen, promote. So relationships are there. So we support those. We help people to come together, all that kind of stuff. So it starts to unfold some responsibilities for us as a network in terms of relationships and what does it mean in an Indigenous construct, knowing that there's a whole host of stakeholders at play here. Our next aim was to, well, if we come together in relationship, that can then facilitate some amazing stuff, whether it's new knowledge or harnessing existing knowledge or whatever, thinking about this. What if we also share expertise of people at the table from a research perspective, right? So that's kind of our second aim, is the facilitate sharing of resources. And in doing so, we intend to help support capacity building around research with stakeholders. So I'm a family doctor. I was never thinking I was going to be a researcher, but by being asked to be an academic to help support a medical school to move forward in some of the issues, I learned and then embraced this thing of research, and from it I realized the power of understanding the methods, the concepts, and the possibility of understanding and connecting to other knowledge platforms via this, that I think was very facilitative of me to understand these systems. And if we can build that into and facilitate that sort of research understanding and capacity amongst various players within our healthcare system, we can add this lens as a strength across the board. So that's kind of also, we can build more and support more individuals that can do some awesome work with us, and then we can all take a break. Hey, Stephanie, at least me. I think you're still really at that stage. You want to do more. I think I want to fish a bit right now. So our objectives, we identified and wanted to like frame a logic model approach so that we can sort of refine what we do. So we have identified 5 areas of domains, objectives we call them, that we do in order to achieve these outcomes. And each of these objectives are linked with key initiatives. And each of these initiatives are resourced with a whole bunch of inputs and all that kind of stuff. And we identify outputs located with each of these 5 objectives. And we have developed an evaluation framework that then chooses some indicators of these things that we have then also started to develop some resources or some tools that tap into what is it that we do as a network that proves that we're actually doing creating some outcomes in communities. So we've been working hard at this at a very logic model evaluation framework, very rigorous, and I've been helping and supporting each of the co-PIs to take leadership of these 5 objectives, and I sit across the boards each of the meetings to help support and make interconnections. So as my role as a leader, I'm there and fostering all those very same aims that I mentioned in the last slide. So the first one is like kind of the basic constructs that we can see within networks that I mentioned. The second one is truly developing a knowledge platform, theory, process, and methods for Indigenous primary healthcare and policy research. And so that's objective two that Rita Henderson co-leads with me. The very last one is the objective that Stephanie Montesente co-leads with Cheryl Barnaby. And these two things I see fit hand in hand in terms of understanding a knowledge and theory platform around primary healthcare and policy through these two. So that's kind of how I set this up and that we've agreed as a group. The two middle objectives, the first one is around building that teaching and learning capacity so that we can build research capacity within our community of whether it's research trainees or maybe it's people like me who was a clinician and then decided maybe I can learn about research, right? Or maybe it's a policymaker or a system lead or a healthcare director that just wants to build capacity around research methods so that they can move their organization forward. The fourth objective was supporting individuals, supporting communities who say, I have a idea. It's kind of a small idea, but I don't know how to move it forward. So we offer seed grants and supportive research support through mentorship and training, connected back to number three, to build capacity, to help people to actually make their really critical, cool ideas, which might be small or big, come to fruition. So we offer seed grants to help that, and we have a call out right now, and hopefully we get a host of people and our groups that want to vie for this money. Can I have the next slide? So I mentioned that each of the objective has a whole bunch of initiatives or activities, and you can see here that we filled our bucket with key specific initiatives that cross cut and connect to each other. So think about, we see this as knowledge exchange, we see this as building capacity, we do things like science cafes so that we can sort of engage with communities and show people what it is that we do so that local community people can hear it in plain language. We also do more formal sort of seminars, so we have one coming up around virtual care and understanding and exploring this. We actually have a forum coming up that will explore more deeply kind of possibilities. So our methods around this knowledge exchange has been grounded in the work that I've been doing with Stephanie and Rita for quite a number of years, that sort of asks us to challenge the typical ways of just sharing knowledge, but to engage in adult learning principles for helping people to integrate and then transform that knowledge using small group based approaches. So we actually have been engaging in some models of teaching and learning in order to like facilitate this shift of a conversation. Anyway, so those are the things that we bring to the table, and all these initiatives and our activities that you see here are intentionally developed, and we hash them out many times, and now we're getting them activated, and it seems to be quite exciting to me. What's the next slide? So I highlighted a host of these things that we are having coming up. So we have, like I say, I stated these things. So we have a seminar coming up. We have a very special seminar on racism and health. Within the educational objective, we want to facilitate conversations, whether it's like journal clubs and all that kind of stuff, with emerging trainees and research and primary health and care and policy staff that are thinking about moving into learning more about research. We offer seminars and all that kind of stuff to support specifically learners, but we have Yin Parody speaking about Indigenous health and racism, and he's from Australia, so we're super excited about that. And I mentioned the gathering concept. We're looking at 5 domains of innovations that we'd like to develop conversation, dialogue, and start helping us to frame sort of courses of action. So we have a 2-hour gathering to explore. Virtual care will be a part of it, but we also want to think about and explore prevention and cultural-based care and gender and all that kind of stuff within this conversation. And those are some of the activities, opportunities that we're offering at the moment. And so that's it for me. I'll hand it over to Leonard, who I look up to and have learned for many years. And Leonard is one of the traditional people and a chief from my community. So it's a pleasure to be able to, and an honor to be able to share the stage with him. So hand it back over to Stephanie to introduce Leonard, or I don't know the plan, but I'll step off. Thank you.
Thanks, Lindsay. So I'm going to ask Elder Leonard Bastine to talk to us about opportunities that he sees the network providing for advancing Indigenous primary health care in the province, and opportunities for lessons learned for other provinces across the country. So without further ado, I'll hand it over to Leonard, and Leonard, please feel free to introduce yourself and share your reflections. Thank you.
Well, first of all, it's a privilege and it's an honor to be part of this virtual network of some very powerful people, and I just have nothing but gratitude for this work, with knowing that it's going to improve Indigenous primary health care. I look at it from the perspective that all of you work for God, and I have an appreciation of the work that you do. I just have nothing but respect and honor for this work, and I look at Lindsay. Known him since he first got on the school bus, going to school in Pincher Creek, and known him since that time. It's been a long time. It's been a lifetime, and I just admire all his accomplishments. What he's done for himself, for our community and the Indigenous community. And so, the support, has to be ongoing from every level for this work. I come from the PIHCI First Nation. I was involved there politically, the chief and counselor for about 20 years. And for the last 20 years, I've been involved with children in care and families. But at the same time, I've still been connected to the political movement, across Canada, mostly, primarily in Alberta. I look at primary health care from the perspective of the and I would say the Blackfoot worldview, and we all know that we have to have water, and so water is life. All of us, we would have no life if there was no water, and there has to be efforts to provide healthy, clean drinking water for the Indigenous communities. There has to be, an infrastructure system that's there. And, the challenges that are there in regards to every area and primary health care is, the poverty. Poverty is a violence. I hate to start going on to this negative side of reality, but it's there. But it's created because of poverty. I look at Alberta, like right now, Alberta government and the citizens of Alberta, are complaining and are suffering because of, I guess the way things have changed in regards to fossil fuel. There's so many things there that are gone because of what has changed. And the change is here, and there's going to be more changes. But in regards to that, there has to be a sharing of the resources, like in Alberta, where I come from, and it has to be done strategically to improve the healthcare system. In listening to Lindsay, there's a lot of thoughts that came to mind, and I think about them, for myself personally, growing up on a reservation and only knowing life from the boundaries of the reservation, and then getting caught up with alcohol. Alcohol was introduced, and legalized on the Pagan Reserve in 1965, and it has forever changed my community. With how we lived and everything else. But despite what occurred from the alcohol, the addictions, and what came after that was other forms of drugs, and now it's opioids. And then I think statistically right now, especially from my community, if we look at the statistics of the people that have passed away, I don't think in my community we've had anybody that was on the reserve that passed away from COVID-19 yet, and knock on wood. But there's been a great number that we're burying almost every week because of opioids, because of alcohol, because of other issues and indicators, and all of that can be looked at as coming from say poverty playing a role in it. I know that we're beating the hell out of this colonization, and TRC, Truth and Reconciliation in regards to residential schools. But we have to jump on that particular bandwagon, if I use that term, to make some changes, and there has to be changes. What I look at and this thought always comes back to me, and I think about my community, but that it can apply to all other communities that have challenges. I look at people like Lindsay, I look at his brother, I look at his family. His family are very successful people. There's doctors, there's lawyers, there's businessmen in his family, and in other families. There's a lot of people that are successful, from education. And I look at the times when they were moving forward, out of what took place from alcohol on the Pagan Reserve. Despite the devastation that alcohol created with the Pagan people, despite that, and on a per capita basis, in Alberta and perhaps Canada, we have very high number of educated people, very successful people. And then my thought process, and I mentioned it to the leadership, the present leadership and the leadership that was there before, I told them, there's challenges that we have, on the reservation, and there's challenges in health and so many other areas. So what you need to do is you need to invite all these successful people, these professional people, and bring them into one room and then ask them, the question is, well, how did you make it? What brought you to success? And what comes out of that room, that would be the technology that's going to make a difference in my community in regards to changing the way of life. And and in that, yes, we need this research team, to assist in that in regards to primary health care. But primary health care is based on dollars and cents. Like for me, I got sick about 4 years ago. And, and it was science and technology and, medical people, the people that work for God, like I mentioned, like you people, and through other sources, I believe in higher power. And, and I look at it as a miracle. Within less than a week, I was healthy again. And I have such gratitude for the science that went into the pills that were given to me, the medicine that was shot into my veins. This is all a part of it. And for me, to look at that gave me, another area of understanding, a breakthrough. Hey, this is all connected. And right now we're talking about primary health care. It's all connected to that. So, I'm rambling on here, but the point, I want to make is that, yes, there's issues that are there, but I cannot overemphasize the issue of poverty. There's, racism. Like for me, I run into it every day, but yet at the same time, I don't take it on. It's just there's such a normal way of me how I handle it, and and yet I get by. It's like doesn't matter where I go, whatnot, it's there, and somehow, some way, hopefully in my time, in my lifetime, that it would be removed. But what creates that stigma of stereotypes and everything else goes back again to poverty, lack of whatever that's going on. So, the racism is there, poverty is there, and I look at it like for me, I give credit to who I am and what I am today, because there was a point in my life where I had to make some changes. Otherwise, to be honest, I wouldn't be alive. And what brought me back to who I am today is I went back to my roots of my culture. I went to the elders, and it's through the elders, through ceremony, and our identity of who we are and what we are. And and as a Blackfoot person, we never lost our culture. We still have our ceremonies the way that we had them prior to European contact, albeit it's a really minority of the Blackfoot people still practicing it. But if it wasn't for that, I wouldn't be alive. I wouldn't be who I am. I wouldn't have this confidence in speaking to you if it wasn't for that, for having that identity, for having that connection to my culture, to my ancestors. My family, we have the gift of caring for a medicine bundle that has been, anthropologists have looked at it and said, this medicine bundle that you have is 5,000 years old. That's a privilege and honor that I have. But at the same time, I'm accountable and responsible for that to be carried on for the coming generations. So I spend a great deal of my time teaching other people about our ceremony, about our culture. Right now, I'm sitting down with a team and looking at how we can retain our language. Because our language is in jeopardy. And if we do not come up with strategy like what's going on with this network today in regards to primary health care, we don't do that with the language, we're going to be the same as a number of tribes in North America that have lost their culture and lost their language. So there are so many areas, but these are the things that I look at that all play a role to healthcare. In everything that I do, every ceremony that I do, I look at 5 things and I pray for them. I pray for the mental, the emotional, the physical, the spiritual, and yes, financial. Those are 5 areas that I put my prayers into for myself, for my family, for the community, the people that I work with, people back home, the leadership. We have to have that, like mental health care, like mentally, I sat down and again, I have gratitude that I had the opportunity of being taught by elders that were from, say, that were connected to my ancestors, 150 years ago. These were elders that I connected to, and they taught me and they shared things with me, and that knowledge that I was given from that's a privilege and an honor. And and I want that to continue. It has to continue for us to move forward. For me, my total thinking is in Blackfoot thinking. At the time I get up in the morning, I connect it to Western worldview, and I look at the best of Western worldview and my traditional worldview, and I put them together, the best of both. I try to, and yet I still fail in so many areas. So primary health care, I look at it, from where I'm at. You have to take care of yourself. You have to look at what you consume. You have to have exercise. You have to do something for the mind. I sat down with this one medicine man. He was a medicine man. people went to him, yes, and he cured cancer and different other types of sicknesses. But one morning I went to his house. He called me over. He said, I need you to bring me from my home to this place and whatnot. So it was an honor for me. I got there and he says, there's three things that are really difficult that I deal with. Number one is cancer. People come and see me. They want me to help them. They want a miracle for cancer. But, they come to me when it's too late. Like they've gone everywhere else and I'm on the last resort and I'm supposed to pull out my magic wand and cure their cancer. They said it doesn't work. But if they came right at the beginning, I'd have a better success rate. He said, yeah, sometimes, of course, sometimes there's miracles. I can help them. He said, but right now amongst our people, there's a sickness. He said, I have no success with it. He said, and I'm really concerned about it. And that's got to do with how we eat. And we're not exercising. We're not doing anything physical. He said, and that sickness is diabetes. He said that the third one, which is the most difficult one, is the mind. And it'll manifest what you think about it. And today we look at it as a major health factor. We have to deal with it. We call it stress. So these are areas that we need to look at in primary health care. And, these are just some of my thoughts. But, I really appreciate you, all of you in this network, the work that you're doing with the belief that it's going to make a difference for health, for me, my family, and the future of the Indigenous communities. So I thank you for listening to me. Maybe I didn't make any sense. Maybe I should be speaking somewhere else, but that's what I come to share and offer with you. Thank you.
Thank you so much, Elder Bastine. That was wonderful. We appreciate your reflections and sharing your experience. I think it really provided a nice context to understanding not just patients' journeys and experiences through the health system through your point of view, but truly appreciate what you've shared about the experience of First Nations in the province and the opportunities that this network can provide for improving the experience and health outcomes of Indigenous patients and ultimately advancing our primary healthcare system in Alberta. With that, I just wanted to thank you all for joining our webinar today. Again, thank you for the invitation to share our network. And just in closing, I wanted to just recap and highlight a few key things about our network and our hope for the future. Innovation in Indigenous primary health care can be achieved in three main ways. And Lindsay really touched upon this. One is shifting our mindsets, right? We need to change the way we think about how we do things, the way we do it, and how we innovate and deliver care with equity as a core concept. Secondly, we can't address wide-scale systemic transformation. We can't achieve systemic transformation without those relationships and trust. And as we've indicated, a big part of our network is establishing and building those relationships and fostering trust with policy and decision makers, healthcare providers, and communities. And thirdly, it's about building capacity. So not just creating mentorship and training opportunities for graduate students who are interested in a career in primary healthcare or primary healthcare research, but as well for the medical profession too. So building that capacity for healthcare providers, those working within the system, so that they can have a better understanding of those core concepts that we introduced, right? So equity being an important one, and working closely with the system to advance our core objectives. So I'll maybe hand it over to Lindsay if he had any other final comments or thoughts that he wanted to share before we close.
Thanks, Stephanie, and thanks for facilitating this broader session for us. It's I really appreciate that, and appreciate working with you. And the stuff that you bring to the table has been really fundamental to expanding our concepts, and it's key. And thanks to Leonard for sharing, discussing the kind of the realities, and discussing it, discussing the things I was trying to describe. As it truly is, right? Fundamentally the upstream issues of poverty, right? Fundamentally the social exclusion that has resulted from that has created a whole host of issues that I challenge our healthcare system, our primary healthcare system, to be engaged with, to help support, to address, to help heal. Those are tall order questions, and how do we do that is the challenge. If we looked at this from a population health lens and saw a concept of social cohesion, saw a concept of what are the issues at play from the outcomes of colonization, what are the components of an Indigenous worldview that support fundamentally good ways for coming together, that through connection with each other, through connection with knowledge, through connection with systems, through connections with creator, facilitates wellness. How do we tap into that in a primary healthcare system that doesn't truly comprehend this yet? And that's where we fit in within Indigenous healthcare and within Indigenous primary healthcare and policy research. We hope to create this space, to facilitate this space, to allow this innovative thinking to come to the forefront, so that we can create change. And so I really appreciate what you shared today, Leonard. It was I think the challenges that we as humans are across the board, and our conceptualizations of wellness and all that stuff are important things to connect to at all times. So I really appreciate hearing from you and listening to you as a community elder, as a community knowledge keeper. So I truly get inspired to how do we play this? How do we work this, right? Some of my other work around diabetes, called Educating for Equity, is focused on understanding the context of how culture and colonization are in a space that, as a healthcare professional as well as a patient, you have to sort out in terms of those things that facilitate this. So you speak to a lot of those things. So thank you. And that's my closing for this.
Thank you so much, Lindsay. And it really is an honor and privilege to work with you. And it's been great just to be through this, to go along this journey with you from the beginning, from our very first engagement session in 2016, and to see this network come alive. So it's great. And with that, I'll hand it back to Jillian, our host, who will moderate our Q&A.
Thank you very much. So Stephanie, I'm going to ask you to stop sharing your screen. And I would ask you to maybe put in the chat the address, the www.IPHCPR address, and that's where people can go. There were some events mentioned during the presentation, some upcoming seminars that look really interesting. So you'll be able to go on that website and find all that information. So I'd like to thank our speakers today. That's an incredibly interesting topic. And I actually, and in listening to the conversation, even though it seems like our challenges are being magnified, no, it doesn't seem like it, our challenges are being magnified, and COVID has certainly hopefully gotten rid of the last of the rose-colored glasses in terms of accepting that we are facing systemic racism. We are facing huge inequities. Poverty is not getting better. We're going in the wrong direction on so many things in our society. But at the same time, listening to Dr. Crochou and Elder Bastian, and I apologize, I know I'm saying your name the French way. It's a little quirk in my brain, and I'm sorry about that. Stephanie, I actually feel very hopeful. I hear a lot about resilience and strength and the perseverance of people who have endured incredible things and who are still moving forward and providing an example for us. And I think in primary care and other areas, we need to pay close attention, because these are, if you can have successes under these conditions, then we need to learn from them. So I really appreciate what you have shared, and I learned a lot from it. And as I said, I think that one of the reasons why we emphasize this tripartite type relationship between researchers, healthcare professionals, and the people most implicated, such as Elder Bastian, is that everybody brings a different perspective, and a much needed perspective. In the research world, we tend to be isolated from the realities of both the clinical context and the lived context. So this has been really helpful and a great example of this type of work. Okay, I have a couple of questions from the audience, which I'll entertain first. Anybody who's attending can put their questions in the Q&A, and I will read them out loud. So the first one, now this has been written specifically for Alberta, but this is not a conversation restricted to Alberta. And the person is wondering, given the provincial government's interest surrounding privatization of health services in Alberta, is there an evolving conversation about the impact this may potentially have on Indigenous health through primary health care, and how your research will be shaped by these changes? So, easy question. But I do know, actually, as we struggle with access, as we struggle with an austerity economy, this is going to come up a lot. So I'd actually like to hear from our panelists let's deal with how you think this would impact primary healthcare first, then we'll deal with the research piece of it. So whoever would like to go first about this.
I'll offer my opinion. For me, I navigate, the health system for what it has to offer, and I get optimum care. It's because of who I know, what I know, and it's how I navigate it. However, a great number of my people do not, navigate it the way I do. And as a result of that, don't get the type of care that they deserve, that they should have, because of systemic racism. And in regards to, this privatizing healthcare, well, again, that's all based on money. It depends on your bank account. So the people that have the resources, that put the people in government, they're the ones that are going to continue to benefit from the work that's being put together today from other strategies and technologies. And truth of the matter is that there'll be another commission set up for the Indigenous people to look at how they're going to heal from from health privatization. Put that out there. It's gonna be an issue because we are going to suffer from it. I mean, the universal health care that's there now isn't working for all Indigenous people. And so this privatization of health is just going to multiply those challenges in every area. I mean, I'm just looking at it from a common sense perspective. So that's my opinion.
Yeah, and I think that that's a concern for all of us. There is, including the Indigenous people, there's a big section of the Canadian population that are essentially, although we supposedly have universal health care, they can't access it. So do you really have health care if you can't access it in a timely way? And that's again where we're seeing a trend in the wrong direction. So I appreciate your perspective, and yeah, doing something after the fact to try and deal with the harm done. We're really hoping with the primary care research, we can start being proactive instead of reactive. We have a very, very reactive system and it's not serving as well. So Dr. Crowshoe, do you have anything to add to that?
Thanks. Yeah. Thanks, Leonard. So privatization, Bill 30 in Alberta. So I think we need to understand what it's been like around the world. Say, look at New Zealand and their mix of a private model with a public healthcare model, and what it means from a Maori perspective, and where Indigenous people within New Zealand get sort of pushed in the system. It's a conversation of health service disparities that are perpetuated by policies such as this, in the reality of like resource limitations, and then just thinking about Joyce Echequan over and over again, and the concept that was stated by those healthcare professionals in the room, really stating that she doesn't belong here, she doesn't deserve what she has because she's Indigenous, and then a perpetuation of hate within their wording towards her. How could we, if privatization creates a situation where previously we have this idea that there is a relationship we have with the provincial and federal governments around the provision of care as a right, as a social justice. It's a right that we have as Canadians, but also there's this other level of an agreement that we have with the federal government via the treaties that then creates this legislational but not truly legislational sort of aspect, but it's truly a deck of a house of cards that is supported by policy and court action, right? That spells out the various jurisdictional issues around Indigenous healthcare. If all of a sudden and the feds feel that there's a portion of that they've transferred to the province for the responsibility. So we have what is our recourse as Indigenous people when the province then shifts that off to some organization that has no relationship with us, that may perpetuate more violence against us as Indigenous people, may see it more, because it's more challenging to work with us because we have a whole host of complexities that are, I think, is beautiful and interesting, but other people find it overwhelming, so therefore they withdraw care, right? And that's the challenge of primary health care and Western systems, that they're not framed for us, and therefore they blame us and then not see themselves as, hey, we're not really set up for this, maybe we need to get set up, and then they pull away and then or provide sort of focused bad care. That's what I see. Privatization could make this worse. But if we could create a situation where we had some core knowledge, core principles, and we still frame this within So this is like, you're talking to a family doctor that doesn't often speak like a family doctor. We're talking about social justice here, right? We're talking about sort of structural competencies and structural advocacies within systems. We're talking about these things that from a many more people in my family. By the way, we also have a judge, and my cousin's a judge. Speak at this level, right? That we push our systems to be more clear. If we can come to the table, we can hopefully make sense of these, push against these policies, make sense of how do we address them if they come into play. I think it puts us at risk, this privatization. Looking at New Zealand, I think Indigenous people are pushed into a system. Looking at America, Indigenous people are pushed into a system that is under-resourced, and privatized models of insurance are not what Indigenous people generally have access to. So I think it creates more problems. I would say that we'd have to use our best knowledge as possible to be able to advocate within a privatized model. Maybe we have to organize ourselves as Indigenous people to hold that private relationship. I would say that within Alberta and across, understanding a tripartite agreement within primary healthcare, so that often we have like primary healthcare as a working group within, say, a health services construct within the province, right? And it's all sort of it changes. Like just in the last few months, it's like been costs have been cut, and so like activities have been cut across the board, and so Indigenous health programming, which is intended to support primary health care, has been severely sort of cut back, right? I just think that we need to like move ourselves away from the shifting tides of being inside a provincial health model, as well as the shifting tides of being inside of a federal health model, right? To be able to like advocate not within the confines and barriers that a system offers, but outside of that. So I'm wondering about a strong lobby group around Indigenous primary health care. Maybe it's a council of some sort that has buy-in from all of the three parties at play. Well, five really, right? With Métis, the urban First Nations, and then the province and the feds, right? To have a council approach that then primary health care becomes a space that then sets policy that the other players have to try to adhere to. But in the current context, we get kind of wiped away because there's a funding deficit. So therefore, Indigenous health becomes even a lower priority. In my experience of years with more funding, there was always like, oh, we don't have enough money for Indigenous health anyway. So, but when it becomes lean, they say, well, we really don't have enough money, so we're going to cut you. But when they have more money, they say, well, we have other priorities, so we're not going to build you bigger. So we're always at risk. And so I think it speaks to the need for us to be super clear of our knowledge, understand what it is and how we could advocate. So work through at a very multiple layers of systems in order to make this. I think it's a long term. So if you think about this as a game, there's a long-term plan here, and it's all about a whole host of plays and a whole host of possibilities that you set up for down the road. So it's a long game. And in my work within the system, within the medical school, it's around activating. Like I can't do it by myself, but if I activate you, and then that person, and that person, and then they're empowered to like, I think I can do this, right? Then all of a sudden we have 1,000 players within a system starting to say, well, let's just do it. This is like a small potatoes because I can easily do this and you can do that, right? But if you just rely on one person to achieve it all, that's impossible. So my role has been activating in a vertical with many horizontal layers all at the same time by creating good knowledge, right? And engaging with people. So that's kind of the answer to what we got to do.
Oh,
anyway.
Pretty straightforward, eh?
Yeah, totally. Long game.
I like that answer though, because the reality is any part of the system we can strengthen, the rest of the system can learn from and benefit. So it's, even though I absolutely agree with you, I think there should be strong Indigenous component. With some of the challenges that have been faced there, anything that works will work everywhere. So it's not just an investment in Indigenous health, it's an investment in everybody's health, and it's for all of our benefits. And I would remind our webinar attendees that the WHO defines health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And I think this is something that we need to keep in mind. And one of the reasons why I'm such a tireless advocate for primary care is primary care addresses that. It doesn't medicalize everything, it addresses people. And I think that with COVID, we have an opportunity to rethink primary care, where it sits in our healthcare system, which at the moment is very much in the periphery, and what other aspects are tied into primary care. So I love that you mentioned social justice. If I had my way, it would be a required course everywhere, not just in medical school. And this is where also investment in education. And I always think it's a little bit of the economics arguments, and I understand what you're saying, right? Your pie never gets bigger, but it's the first one they start to trim, when cost cuts, and we do need to be really big advocates around that. And that's the other thing people didn't realize until COVID hit, is how little funded primary care has been and how little funding primary care research has received. So this is why I was really thrilled to see your collaborative, especially from the research side. And that this can be directed by and for Indigenous health. So I know Neil has asked how you joined the network. So in terms of you've got your research grant and you've got your site there. Is this something where you're open to membership or collaborators? I know you've got events and other stuff going on. What's the approach there for the network?
I can take it, or Stephanie, if you want to.
Stephanie might be attending baby.
Yeah. Go ahead, Lindsay.
All right. Well, we'd love for people to check us out and join. These initiatives are open to all. The seed grants are in relationship and in partnership with the Indigenous community, right? So that's kind of where there's some key restrictions. Some of the a key component of the educational funding, like traineeships, are intended to like build capacity with Indigenous trainees, but we also see a broader perspective of connecting and supporting non-Indigenous sort of professionals and trainees to engage in close with us as well. My perspective is teaching, learning, research, training. There are more non-Indigenous people that do this job with us, and we have to train them well to create that vertical, horizontal sort of structural sort of capacity amongst many people. So excuse me. So yeah, so if you check out our website, you can come on board and we can like see how we can work together, whether it's like through knowledge exchange or through identification of some interesting and cool sort of research opportunities to develop new knowledge, or or within our educational components. Those would all be welcome and open for collaboration and connection.
Thank you so much. So we're coming
Just
towards
to quickly
Sorry,
add, Jillian, is I think that's the beauty of a network, right? As our network grows, we hope to bring together a community of practice, so to speak, right? Those who are working across the sector within different roles. So whether they're policy and decision makers, providers, community, trainees, and as Lindsay mentioned, I think the first step is get engaged, get involved, check out our webinars, seminars, reach out. And as we start to learn more about those who are participating in our activities, then hopefully we can keep track of that somehow and create some sort of community within our network, right? Of people who share common goals and vision for transforming Indigenous primary healthcare in Alberta.
Thank you. So we are getting towards the end of our time. I do want to thank our speakers. It was a great talk. I do also want to thank, so PIHCI is a network of networks. We all have funding from CIHR, the Canadian Institutes for Health Research, as well as partnered funding. So there's a lot of people and organizations that have contributed to this research initiative. I was very pleased to see the Canadian Institutes for Health Research investment into these NEAR grants. There are several of them across the country, so maybe we'll get to hear from some more teams or host some joint learned lessons. Of course, COVID has, this got announced and boom, pandemic. So that made things a little more interesting for these networks that are trying to get up and running in these capacity development activities. So I do want to acknowledge those funders. At the end of this session, there should be a survey activated. I'd please ask that everybody complete this. This helps both our speakers and us plan for future events. And our next seminar will be January 26th, so you can look for that announcement. But Alder Bastian and Dr. Kershew and Stephanie, thank you. That was really great. And I really hope we can bring you back at some point and hear about your initial results and lessons learned, and fantastic initiative. And I also want to thank our speakers. This is really volunteered time on their part, and I very much appreciate it. And we will be posting this on the PIHCI website. So if you think that somebody needs to hear this and see this, you can refer them to there. And we'll also at that point include the web address for this network, so that if you haven't jotted it down or you forget, you can go on our website and find it, and also join their seminars and events and activities. So thank you so much. And I hope everybody has a wonderful week. And I will see you at the next seminar. Thank you so much for joining us.
Great. Thank you, Jillian.
Thank you.